Welcome to the deep dive. Today we're plunging into a really interesting area, pulling from some detailed pediatric revision notes we've got here.
That's right.
Specifically, we're looking at vesicoureteric reflux, or VUR.
VUR.
We've got quite a stack of info, and our plan really is to cut through it all, pull out the absolute must-know points from these specific notes and help make them stick for you, especially if you're, maybe revising or heading into something like the MSRA.
Exactly. And this isn't just about rote memorization, is it? It's really about understanding the why behind VUR, the so what for the child.
Right.
And what you absolutely need to nail down for high-yield revision.
Okay, so let's get straight into it then.
Yeah.
Let's unpack this first big question. What exactly is vesicoureteric reflux? What are we fundamentally talking about here?
Well, think of it like this. The notes describe it as a situation where urine basically takes a wrong turn.
The long term.
Yeah. So normally, urine flows one way, right? Kidneys, down the ureters, into the bladder, job done until you need to pee.
But with VUR, some of that urine flows backward from the bladder back up the ureters.
Okay.
And, sometimes it can even get all the way back up to the kidneys.
And why does that happen?
It's because the valve mechanism, right, where the ureter joins the bladder, isn't working properly. It's supposed to stop that backflow.
Like a one-way valve in plumbing.
Exactly like that. But here, it's leaky, allowing that backward flow. It becomes sort of a two-way street when it shouldn't be.
That's a great analogy, the faulty valve. So why does the valve fail? What causes that?
So the notes break this down into two main causes, the etiology they call it. You've got primary VUR and secondary VUR.
Primary and secondary, okay.
Primary is the big one, the most common. This is something a child is born with. It's congenital.
Ah, right from the start.
Yeah, a developmental issue with the valve itself. Maybe how the ureter inserted into the bladder wasn't quite right, or the tunnel through the bladder wall is too short, things like that.
Okay. And secondary?
Secondary VUR develops later. It's usually because of something else going on. Like what?
Things like recurrent urinary tract infections, UTIs. The inflammation can mess with the valve.
Oh, okay.
Or problems with the bladder itself. Maybe it doesn't empty properly, or there's an obstruction somewhere lower down.
Like blockage.
Exactly. That increases pressure in the bladder and can literally force urine backward. So, primary is structural from birth. Secondary is usually acquired.
That distinction makes sense, structural versus acquired. So knowing that, are some kids more likely to get this? What do the notes say about risk factors?
Yeah, they list a few key ones. Family history is definitely in there. It can run in families.
Okay.
Female gender is mentioned as a risk factor. Also, young age infants and young children are most common.
Makes sense if it's often congenital.
Right. And obviously, other congenital urinary tract abnormalities increase the risk. But interestingly, UTIs pop up again here.
As a risk factor and a cause of secondary VUR.
Exactly. It's a bit of a vicious cycle, you see. VUR makes you more prone to UTIs because urine sits around, and the UTIs themselves can worsen the VUR or even cause it in the secondary cases.
Right, that cycle is important. Okay, let's get a bit more technical then. The pathophysiology. How does this backward flow actually, cause trouble in the body?
So normally that valve closes tight when the bladder squeezes to empty, preventing urine going back up.
Right.
In VUR, because it's faulty, urine does reflux back up the ureter, sometimes into the kidney itself. And the problem is kind of twofold.
Okay, what are the two things?
First, that urine flowing back up or just sitting there is a perfect place for bacteria to grow. That leads to those recurrent UTIs we keep mentioning.
Yeah, the infection risk.
Yeah. And second, and this is really critical, the pressure from the reflux itself, plus repeated infections actually reaching the kidney tissue. That causes damage over time.
Damage to the kidney.
Yes, specifically inflammation and infection of the kidney called pyelonephritis. Over time, this leads to scarring of the kidney tissue.
So backflow plus infection equals potential kidney damage.
Got it. Now, if a child comes in maybe with recurrent UTIs and we're thinking VUR, what else should be on the radar? What differentials do the notes mention?
Well, the notes point out quite logically that you need to consider recurrent UTIs themselves, just as a standalone issue, although they're obviously linked.
Sure.
Urinary tract obstruction is another big one. A blockage can cause similar symptoms, pressure buildup.
And could even cause secondary VUR, as you said.
Precisely. And then, just broadly, any other anatomical abnormalities of the urinary tract need to be considered. They're often tangled up together.
Okay. And how common is this? What do the notes say about epidemiology, say, in the UK context?
The statistic given is around 1 to 2% of the pediatric population, so not super rare.
1 to 2%.
Yeah. And it's most commonly diagnosed in infancy and early childhood, often picked up after that first UTI investigation.
Right, so what does it actually look like? Clinically, how might VUR present in a child according to these notes? Well, the really important thing to remember for revision, I think, is that it's often completely asymptomatic.
No symptoms at all.
Often, yes. But the single biggest clue, the most common way it's found, is those recurrent UTIs.
Okay.
Especially febrile UTIs, the ones with a fever. That fever is a big red flag because it suggests the infection might be up in the kidneys, pyelonephritis.
Gotcha. Any other signs?
The notes also list things like just general fever, maybe some abdominal or back pain, peeing really frequently, or urgency, like they really have to go right now.
Less specific, though.
Exactly. And in really severe cases, if there's already significant kidney damage, you might even see signs of renal impairment.
And the notes mention some specific scenarios for presentation, too.
Yes. They highlight a few key ways it comes to light. One is even before birth, antenatal hydronephrosis. Swelling of the kidneys seen on an ultrasound during pregnancy because urine is backing up.
Wow, okay.
Then there's the classic, like we said, recurrent childhood UTIs leading to investigation. And the third one they emphasize is reflux nephropathy.
Okay, let's pause there. That sounds important. Reflux nephropathy. Break that down for us.
It is important. The notes define it specifically as chronic, meaning long-term pyelonephritis that's secondary to VUR.
So, kidney infection and damage caused by the reflux over time.
Precisely. Kidney damage and scarring due to those repeated infections hitting the kidney because of the reflux. And the notes make a really, really key point here.
What's that?
It's the commonest cause of chronic pyelonephritis in children.
The commonest cause. Wow.
And this is where it gets super high yield for revision. That scarring, the reflux nephropathy, can lead to major long-term problems, especially hypertension.
High blood pressure. How?
Because the scarred, damaged kidney tissue can start pumping out renin inappropriately. Renin is a hormone that raises blood pressure.
Ah, so the kidney damage itself triggers the high blood pressure.
Exactly. Understanding that chain reaction. VUR leads to potential infection, leads to scarring, reflux nephropathy, which can then lead to hypertension. That whole pathway is critical to grasp.
That connection is vital. Okay, so if VUR is suspected, how do doctors confirm it and figure out how bad it is? What investigations are listed?
Right. Diagnosis. The main test mentioned is imaging specifically, the voiding cysterogram, VCUG.
VC?
Sometimes called an MCUG, micturating cysterogram. Basically, they put contrast dye into the bladder and take x-rays while the child pees.
To see if it goes backwards.
Exactly. You can literally see the reflux happening. A renal ultrasound is also crucial. It won't diagnose the reflux itself, but it shows the kidneys, the ureters.
Checks for damage.
Yeah, looks for size, shape, any swelling like hydronephrosis or signs of scarring.
Okay, what else?
Urine tests, of course, urine culture to actually find the UTIs when they happen. Kidney function tests, blood tests, usually to see if the damage is affecting how well the kidneys are working. And importantly, for checking that scarring we talked about, the reflux nephropathy, a DMSA scan is mentioned as the best test for that.
DMSA for scarring. Got it. And the notes mentioned grading the VUR. That sounds important for management.
Absolutely crucial. The VCUG findings are used to grade the VUR on a scale of I to V. And this grade heavily influences the management plan and gives an idea of the prognosis.
Okay, can you walk us through the grades?
Sure. Grade 1 is the mildest. Reflux only goes partway up the ureter, doesn't reach the kidney collecting system, and there's no widening, no dilatation.
Grade 1, just into the ureter.
Grade 2, reflux reaches the kidneys collecting system, the renal pelvis, but still no dilatation.
All right.
Grade 3. Now you start to see some dilatation. Mild to moderate widening of the ureter and the renal pelvis, and calluses the cups inside the kidney.
Getting more significant.
Grade 4, more dilatation of the pelvis and calluses, and now the ureter starts to look tortuous, kind of twisty and winding.
Okay, twisty ureter.
Grade 5, that's the most severe. Gross, really significant dilatation of the ureter, pelvis, and calluses, and that ureteral tortuosity is much more pronounced.
Wow, quite a range.
Yeah, and knowing that grade is vital because generally higher grade means higher risk of kidney damage and influences treatment choices.
Right, so that leads us to management. Once it's diagnosed and graded, what are the options according to these notes?
Well, it's not one size fits all. The notes stress it's individualized. It depends on the grade, the child's age, whether there's already kidney damage, if they're getting lots of UTIs.
Makes sense.
For the milder grades, say I or I, especially in younger kids, watchful waiting is often an option.
Just keep an eye on things.
Yeah, with regular checkups, maybe repeat ultrasounds, because VUR, especially lower grades, can actually resolve spontaneously as the child grows and that ureter-bladder junction matures.
Oh, that's good news.
It is. Now, often combined with watchful waiting, or for slightly higher grades, or kids getting UTIs, is antibiotic prophylaxis.
Low-dose antibiotics daily.
Exactly. The idea isn't to treat the reflux itself, but to prevent the UTIs that cause the damage in the presence of reflux.
Preventing the consequences.
Precisely. And then for the higher grades, grades the fourth or V, or if there's breakthrough UTIs despite antibiotics or worsening kidney damage, then surgical intervention comes into play.
To fix the valve.
Yeah, there are different procedures to essentially rebuild or reinforce that valve mechanism to stop the reflux.
Okay, so watchful waiting, antibiotics, or surgery, depending on the situation. What about the outcome? What's the prognosis generally like based on these notes?
It's variable, as you'd expect. Depends heavily on that initial grade, whether complications like scarring developed and how well it was managed.
What
Overall, the notes are quite positive. With proper diagnosis, the right management approach, and good follow-up, most children do achieve good outcomes. The main aim is preventing that long-term kidney damage.
Which brings us neatly to the risks if things don't go well. What complications are listed?
The main ones highlighted are pretty logical follow-ons from what we've discussed. Recurrent UTIs, obviously. Kidney damage or scarring, that's reflux nephropathy.
Right.
The development of high blood pressure, linking back to that renin production from scarred kidneys.
That crucial link again.
Yes. And then, in rarer, more severe, or perhaps poorly managed cases, it can progress to chronic kidney disease or even eventually renal failure.
Serious stuff.
Definitely reinforces why catching it and managing it appropriately is so important. It's all about protecting kidney function long term.
Absolutely. Okay, so we've really gone through this stack of notes now. Definition, causes, how it works, what it looks like, investigations, grading, management, outcomes. For your revision listener, the absolute key is connecting these dots. Don't just memorize lists. Think.
Yeah.
How does the faulty valve cause reflux? How does reflux plus bacteria cause UTIs and pyelonephritis? How does that lead to scarring?
And how does the grade influence whether you watch, give antibiotics, or operate?
Exactly. Understanding that whole cascade structure, function, infection, damage, long-term consequences like hypertension, that's what makes it stick.
And maybe one final thought connecting this to the bigger picture.
Yeah.
Managing VUR isn't just about the childhood phase. Well, think about long-term kidney health. For children who've had significant VUR, especially with reflux nephropathy, the need for vigilance doesn't just stop when they turn 18.
You mean monitoring later in life?
Yeah, potentially keeping an eye on kidney function and definitely monitoring blood pressure as they grow into adulthood. It raises that question about the journey beyond the initial treatment, doesn't it? Ensuring lifelong kidney health.
That's a really important point for long-term perspective. Okay, well, that wraps up our deep dive into vesicoureteric reflux, digging into these pediatric revision notes. We've tried to pull out the core info, connect it all up, and give you a hopefully clear, high-yield picture.
Yeah, hopefully breaking it down section by section, highlighting those links, makes what can seem like a complex topic a bit more manageable and memorable for your revision.
Absolutely. And if you are deep in revision mode, especially for exams like the MSRA, you might find some fantastic resources over at PathMSRA.com.
Definitely worth checking out.
And also remember, there's FreeMSRA.com too. Lots of good stuff there.
Great resources.
So thanks for joining us on this deep dive.